And what I'm going to talk to you about today is, how can we sort of shift the criteria for evaluating the work of qualitative researchers to enable them to progress more easily or quickly in terms of both hire and promotion. And I don't know if Steve Durant is here. He's my PhD student, and he's helped me with these slides. I just wanted to thank him for that. He and I were brainstorming around what sort of visual aid could we use to tell this story. So we went with Snakes and Ladders. So Snakes and Ladders, of course, is a board game. It originated in India. When it was transported and westernized, they changed the game slightly. So in the Indian original version, there were more snakes than ladders. And so I don't know how many of you will feel in terms of thinking about your own career progress if you have more snakes or ladders. I just wanted to start with this really great quote from the Slow Professor, quoting another researcher who said, "If we ask academics to hold students in a space of vulnerability and uncertainty in which they can embrace their own beings, it is necessary that we create the kind of environment where academics can explore their own vulnerability and uncertainty." And for me, CQ is that sort of safe place. And I hope it is for you today as well, and that you'll feel quite able to share your thoughts and experiences on this topic. So what I'm going to do today is just introduce the project and give a little bit of background. I'm going to talk about the problem we identified, the approach we're taking, just briefly mentioning some of the work, including the work of Mathieu Albert, which sort of gave rise to this project, and the development of what we called the CQ Impact Appraisal Task Force. We did an organizational scan that I'm going to share with you of faculties of health science across Canada. And then I'm going to move to introducing the CHR framework for research impact, on which we applied a Foucauldian discourse analysis and have made recommendations for change. And then we're going to get to the feedback section. So the problem, as all of you doing qualitative research would know, is that qualitative research often doesn't fit the paradigm of sort of basic science in health research. So it's very different from quantitative research in this way. It's an anomalous science. We're also currently in an environment where there's an emphasis on extreme productivity. And as all of you would know, high quality qualitative research is time consuming. So the majority of the work has to be done by the principal investigator. It's not like doing work with administrative databases, where you can shift a lot of the work to a trainee, for example. And in addition to that, the impact factor for most health services or sort of qualitative journals is lower than clinical journals. And as some of the medical journals, like the recent controversy in BMJ, of course, over their new policy to reject qualitative studies as a matter of mandate. And I think also there we feel torn as qualitative researchers, because even when we publish in higher impact clinical journals, we're often restricted to 2,500 words. And so what we're producing is not necessarily what we want to be producing. So in the broader context, just for anyone here who doesn't know this, there was a shift where all health researchers had to apply to CIHR rather than SSHRC. And this has had profound implications that have been well documented for social science as well and qualitative researchers. We're also in an era of the rise of big data. So I'm sure everyone has heard about the concept of big data and all the excitement over using it. They recently put in, I think, a center for artificial intelligence here at the university. There's a lot of sort of excitement and push around that as well. I also think knowledge translation itself as CHR has been a problematic concept, and so my own PhD research located KT as the managerial arm with EBM. So it's really what allowed EBM to be taken up in practice. So I think there are some problems with asking us to continuously show the impact of our work, even before we've in fact done the research. At the same time, there's been a shift to donor funding in hospitals. So those of you working in hospitals will have experienced this. So this is often non-peer-reviewed funding, equally problematic, and with unclear relationships with the donors in terms of the type of research you're allowed or expected to do. And then finally, we have the push for innovation. And for me, the word innovation masks an emphasis on commercialization. So if you look closely at documents where they're talking about innovation, they don't mean innovation as in the arts-based research that Janet Parsons does, or Pia Contos. They're talking about research that will translate into dollars. So for qualitative researchers, then, the common thread in our research is not always content, but it could be content as well, but it's often our methodological approach. So when I think over my own career, what holds it together is it's sort of grounding in institutional ethnography, which is the approach that I most often use. And even when I'm not using it, I'm drawing on those concepts. But building conceptual and methodological expertise is often not acknowledged by hiring committees or promotion committees, as those of us who have sort of faced those committees know. And so we have stories of the ways in which this has damaged the progress of some of the faculty members. So our solution here at CQ was to establish this task force to conduct the organizational scan, to write a report, to apply a discourse analysis I'm going to share with you of CHR's framework of research impact, and then add our own modifications. Here are the people who contributed tremendously to this project. So Steve Durant, Joan Eakin, Denise Castaldo, Brenda Gladstone, Janet Parsons, Elizabeth Peter, Jay Shaw, and I also wanted to give a special thanks to Andrea Carson, who's the coordinator of CQ, if you don't know her, and she kept us going in terms of our meetings. We're also building on a really solid foundation with this work, so I want to, this isn't exhaustive, but I want to recognize some of the work that's been done before us. So of course, Mathieu Albert's work, where he looked at who's on governing council at CIHR, and of course there's no social scientists, let alone qualitative researchers. And so he talks about the impact that has on what type of research gets funded. Pia Contos and Elisa Grigorovich did a presentation here in February, Sleight of Hand or Selling Our Soul, talking about, how they sort of survival tactics for critical qualitative health researchers in a positivist world. And then there was also a really wonderful publication I'd urge you to read by Corinne Hart, Marcia Facey, Janet Parsons, Holding Firm, Power, Pushback, and Opportunities in Navigating the Liminal Space of Critical Qualitative Health Research. And here they really they use themselves really as case studies for some of the problems that we're going to touch on today. So the organizational scan. So we wanted to know what are the policies across Canada in relation to promotion. Because we wanted to originally create a framework to support hiring and promotion, and we wanted to be able to identify and describe what are the formal institutional processes of departments and schools within faculties of medicine. And we looked at health sciences faculty and faculties of medicine, not to sort of exclude other faculties of health science, but really to act as a proxy for them. And we also looked a little bit outside medical schools and internationally. So what do we find? Not very much. Interesting. There were few relevant studies in the scholarly literature. No one had performed a detailed peer-reviewed study of promotion for qualitative research experts. When we scanned the 14 medical schools, six of which are in Ontario, by the way, we found that the general guidelines don't actually explicate any publicly reported metrics they don't actually specify any quantitative criteria for assessing the careers of researchers. And instead, they sort of tended toward a very broad definition of scholarship. Some of the faculties we looked at also said that they would balance their consideration of quantity by also considering things like quality or creativity. But again, I'm not sure that they're using quality and creativity in the way that many of us would. So quantity, quality, creativity. These were sort of the three criteria that seemed to come up on the school's websites. But these terms are almost never defined in a clear way. And this seems to have the effect of giving very broad discretionary power to chairs, deans, and departmental and faculty committees. So it doesn't actually necessarily create a wide open space where there could be more sort of possibility than pitfall for us. And in fact, that vagueness might leave room for, informal standards or unspoken standards that clearly give preference to certain types of scholarship. And they also, while they don't count on sort of bibliometric metrics, they don't talk about counting number of publications or assessing impact factor, they also don't say that they won't. So as many of us know from experience of being on these committees, or even actually judging student awards, these are the metrics that are most heavily used. So frequent references to boards of reviews and departmental authorizations that we looked at made it really clear that they were unclear around how they use this discretion. And obviously, it would be difficult to find out what the unpublished policies are, except, actually, interestingly, by qualitative research, speaking to people who've sat on those committees. So really what we get from this organizational scan was very little insight into what's happening, how the types of problems we know and we're facing are institutionalized. So we have our stories from the field. However, we do know we've had countless stories of qualitative research manuscripts rejected from clinical journals, and often for very sort of specious and irrelevant reasons. So my favorite is always, your study would have been greatly strengthened if you had a biostatistician on your team. And I wanted to write back and say, yes, he could have brought us coffee. So it makes, I'm not sure what other role he would have played on a qualitative study. Actually, Katie Dainty and I worked together at Sunnybrook for a time, and we started collecting our favorite sort of reasons for rejecting our manuscripts. And similarly with grants, right? Getting grants rejected either by a complete sort of non-qualitative expert, or sometimes even by qualitative experts who are of a particular methodological stripe. So you're doing an institutional ethnography and you get reviewed by a grounded theorist and most of the comments are around why your study isn't a grounded theory study. So I think we need to look inward a little bit too and see how we collaborate with each other. This is obviously unintentionally, and make sure that we ourselves are not the ones who's sort of cutting off an important qualitative study from being funded. And then of course, we also have the stories of people either having hire or promotion denied. I most recently was interviewed for a chair position, and after going through the entire process, they said at the end, well, the real problem here is that only 40% of the committee supported qualitative work. And I thought, well, you knew that at the beginning, so it's a funny kind of process when that happens. So given that we didn't turn up very much that was helpful in terms of looking at that environmental scan of faculties of health across Canada, decided to look at the CHR framework to measure the impact of health research. So CHR framework has 4 categories, or what they call pillars of impact. Advancing knowledge. This category includes discoveries or breakthroughs, contributions to the scientific literature, and the development of skilled researchers. It includes in what they call all of these. This is verbatim, by the way, from their website. Informing decision making. This category includes the impacts of research in the areas of public, clinical, and managerial decision making, practice, and policy. We have a category called health, and this relates to advances in prevention, diagnosis, treatment, and palliation. And then economic. And their economic category is divided into 3 subcategories: commercialization, of course, of discoveries, direct cost savings, and human capital gains. Okay, so this is clearly a snake on our road to success. So we applied Foucauldian discourse analysis. We want to look at, sort of pay very close attention to the words that are being used, what they allow or don't allow us to consider under the category. So let's look first at advancing knowledge. So discoveries or breakthroughs are the first thing that is referenced here. The problem with that right off the bat is that very few advances in knowledge are made in a breakthrough kind of way, right? So knowledge production is incremental. If you look at the top of the hierarchy of research evidence that CIHR itself promotes, meta-analysis of systematic reviews is number 1. It's the gold standard. That is not a breakthrough. And that is definitely incremental knowledge. But anyway, nevertheless, that's the first emphasis we get from CIHR. In addition to almost never happening in real life, we do tend to associate it with bench or clinical investigations. We think about the race for the cure for cancer, right? And so it's a widely used concept both in academia and in the lay media. So qualitative research, particularly critical forms of it, actually challenges the social production of knowledge. It challenges existing knowledge. And so in doing so, it may be making what we could term as conceptual breakthroughs. The word scientific in this category can bring to mind very much that sort of conventional positivist notion of the word science. And again, CQ is trying to address this with their new slogan, doing science differently. So we shouldn't be afraid of using the term scientist to describe the things that we do, even as we see, all the flaws in that concept. And qualitative researchers also need to be able to clearly articulate how such terms apply to their research. Okay, so let's look at the next criteria, which is informing decision making. This category includes the impacts of research in the areas of public, clinical, and managerial decision making, practice, and policy. So, as any of us know who've tried to work with, for example, the Ministry of Health, quantitative research, having numbers, tends to be considered sort of the strongest level of evidence and is often preferred. However, I just want to point out that we also know as critical scholars that it's not as simple and straightforward as producing the best evidence, quantitative or not, and that is automatically what gets taken up in practice. So there's all the politics around knowledge production and all the sort of hidden politics of what research study gets implemented, what we take up, what we ignore. And as already mentioned, the widely used sort of model of levels of evidence doesn't even consider, qualitative research isn't even on the board. Case studies is what they consider the lowest form of evidence, and they're thinking about clinical case studies. They're not talking about case studies in the way we would use it. So what would we say to this? So qualitative researchers, of course, do make substantial contributions to public knowledge that is often not easily captured by the type of criteria that emphasizes measurement or dissemination to high-level policymakers and decision makers in government. Also, because we're in health research, I would argue that clinicians are often most likely to be connected and networked with the Ministry of Health. And it's harder for a qualitative researcher or a social scientist to sort of find those kinds of workers. We may take, and we do take, our research results into a sort of a broad range of different public domains, but the way we do that, the format that we have for doing that, and the people that we're networking with might look quite different. And for example, a qualitative researcher may engage in a research-based theater production for healthcare providers, rather than being a participant in a committee developing new professional guidelines. And I'm thinking here, of course, of the work of Pia Kontos. So our third category, informing decision making. This includes the impacts of research in the, oh, did I not just do that?
Yeah.
Yes, I did. Health. Sorry. So the third category is health. And when they define health, you see their emphasis going to prevention, diagnosis, treatment. So really clinical activities. We're talking about clinical research here. And that often isn't inclusive of qualitative research. So we need to sort of elaborate this one in a way to properly acknowledge the different ways, both indirectly and directly, that qualitative research contributes to these clinical domains. And we often make that impact by challenging key conceptual premises of healthcare organization and healthcare practices. So, for example, revealing any inappropriate or inequitable assumptions underpinning accepted or unquestioned ways of preventing, diagnosing, treating, or relieving suffering. So we need to find a way to reframe this evaluative framework in a way that allows us to acknowledge indirect contributions at the conceptual, theoretical level. And then finally, economic. And this category is divided into commercialization, direct cost savings, and I don't even know what human capital gains are, but clearly this category is not easily aligned with qualitative research. And in fact, often what our work does is shine light on the fact that a lot of healthcare in its organization is sort of being driven by a business model that has more focus on efficiencies and economic savings than it does on actually promoting health and wellness. So I'm not sure exactly what we can do with that. But I'm being facetious, there are things that we can do to sort of recognize what the economic value of qualitative research might be. So we might consider alternate criteria. That first of all, commercialization is not the only way to capture the spread of ideas. I think the problem, though, is that commercialization provides much needed dollars for universities. Also, technology can refer to modes of conceptualizing problems and solutions as much as to material products. And of course, economic outcomes of research go beyond the administrative. So how would we sort of reword, therefore, this framework? So here's the proposal, and now we're getting into the ladders. So I don't know if you can see the color difference here, but okay, so in green you have what we would add. So they say this category includes discoveries, breakthroughs. We would add new conceptual and theoretical understandings, contributions to both positivist, post-positivist, constructionist, and critical approaches to the scientific literature. Back to CIHR's wording, and the development of skilled researchers, which we would add, including significant involvement in applied research in hospital or other settings. For decision making, CIHR says, or states, this category includes the impacts of research in the areas of public, clinical, and managerial decision making, practice, and policy. We would suggest adding with an expanded definition of what constitutes evidence to include findings from qualitative studies and of who decision makers are and who can benefit from and take up findings. So a really expanded view of who is or can be impacted by research. Health. So we know their sort of the clinical focus of their framing of this. We would add including advances in how we understand and approach public health and clinical issues, so bringing public health in here as well, in how patient and healthcare provider experiences and the structure and processes of health systems are positioned and implicated in healthcare functions. And then finally, economic. we would want to bring into it, into the definition, social capital gains for patients through research that positions patients and their families at the center of research inquiry. And of course, CIHR really is asking everyone now to include patients in their research grants. They have something called the SCORE, which is a really complicated grant that I can't make heads or tails of. I don't know if anyone else here can speak to that, but it's a very complicated grant process. But the idea of it is that we're going to bring patients into research, but often two problems I've noted is what patients get brought into it are often not the most disenfranchised. They're often sort of very middle class patients who are well educated. And then also the mechanisms by which they're brought in are very, very unclear. So are they just a tokenistic sort of value add of, patient of N of one, or are they brought in a more meaningful way? So that is the work that we've done. To date, the scan and our sort of critique of the CIHR framework of impact, and now I want to turn it over to you and try and have some dialogue about this.